Good morning. For patients who are not burned by water skis on fire, how will ICD-10 affect the interaction between the physician and the patient? Will it be invisible to patients, or will it change the patient experience?
The ICD-10 codes include one additional number, which is a very important. It's actually, I don't think you're going to see much change immediately, but it will provide more information to those that study the data and figure out what patients are coming in for and how they're being treated. So it's a long-term effect. Maybe 3, 4, 5 years from now, some of the changes in treatment patterns may well be driven by these ICD-10 codes because of the information that will be accumulated by that extra digit in the code. Because that extra digit breaks down the definition of what's wrong with the patient in a new way. That's why we have 46,000 ICD-10 codes, and that's also why, by the way, we found some, really crazy ones. But ultimately, this, I think, is just going to be more data for the data mining and for making decisions about how care is delivered.
Considering the need for self-participation by the patient in decisions about care, my question would be, what is a good model of information provision to the patient? Where does the patient go for reliable data from this data mine that's being produced?
I hate to use the term Google because, Google doesn't curate the importance of information, but there are enormous resources, MyMD, in which people write about their experiences. I can tell you there are some excellent models in oncology and cancer. I happen to work on a cancer called multiple myeloma. There are foundations that patients can go to for very good information. And as you can imagine, when a patient is diagnosed with a particular disease, the incentive is to find everything out you can about it. And I think the model in many cases are many of these diseases have some very strong patient advocacy support groups and foundations that people can go to. So I think as a model, some of the cancer foundations and support groups are terrific resources for patients to go to.
Thank you.
Good answer.
So when I need a new knee, how do I find out where to go get one?
Yeah, I mean, there's a couple different options, right? So you can go to Google, you can go to company websites. So once you see, that Zimmer has a knee, Blue Belt has a knee, whatever it is,
Well, yeah.
But you again, you have a network that you should look at, starting with your family physician.
Actually, Eric,
He's going to disagree with you.
I am.
That's why we put him in the middle.
so I can elbow me from either side. So we have this publication, Orthopedics This Week, and we asked orthopedic surgeons, who would you want to do surgery on you? And so we published that list, and you guys can go and Google Orthopedics This Week, and it will give you the list of the best knee surgeons in the United States, the best ankle surgeons, the best spine surgeons, and it's by their peers. They didn't pay to get listed. It's a real legitimate list. But of course, we are trying to get away from that, right? We want to make everybody excellent. That's the goal. But in case you want to know where to get your knee done or your ankle or whatever.
So is the best guy that does hand surgery in Delta on that magazine, does he pay for that ad?
No.
So,
And Delta. Yes, sorry about that. Yes. I wasn't thinking Delta Airlines.
Yeah.
Yes, he pays for that ad. Yes.
Robin, is the question put to those surgeons, if money were no object,
Right.
who would you like to do your knee surgery? Because some of us need to rely on reimbursement.
Exactly.
care,
No.
et cetera,
No.
so-
No. It's bottom line. Who would you trust? It's a trust issue. Who would you trust to take the best care of you for this surgery?
You know the Minneapolis St. Paul magazine has, I hope nobody's here from that. The Minneapolis St. Paul magazine does, top docs. My daughter worked at that magazine for 3 to 5 years. I hesitate to tell you how they came up with the top docs. Just be a little cautious in identifying your top docs from Minneapolis, St. Paul. She doesn't work there anymore, so I think I'm okay.
So I would probably use my neighbor because he's a very funny, nice guy. His explanation for orthopedic surgeon, he said, and I was in medical school, the dean came to a bunch of us. He said, you're the dumbest guys. We want you operating as far from the heart as possible. And I said, I don't believe that. I was like,
These are my people. This is what I do.
yeah. I don't believe that. I think you'd be perfectly fine as a heart surgeon. He always seems to have a new car, too. Yeah. Another question, please. Sorry.
It seems that a couple of the trends that you talked about this morning might be at odds, and I want to know if you could talk a little bit more about that. So one being the outcome-driven single cost approach, that you get one price for each service or each outcome, and the other being individualized care, and your personal story of how you pushed for something that was more expensive because it was the right approach for your child, and how those two trends might be at odds.
You know what? I think they are at odds. I think this trend to create homogeneity of care and outcome, I think you're right. Actually, I think that individualized care is something we want, each of us, for ourselves and our family members, and it could cost more. Perhaps it's cheaper in the long run. I think the resolution of that inherent dynamic, perhaps, lies with, it's a hopeful statement here, wise people at the payer level who can sort of reconcile those two things. But I think with dollars pushing it and with consolidating payers, fewer people making these decisions on who pays for what, I honestly think it's going to this, it's called the McDonald's approach. In other words, limited menu, lower prices, but consistently high quality hamburgers. Wherever you are in the country, I kind of think that's where it's going.
I think there is a potential discord between standard of care and individualized medicine. And I would like to see it be standardized process instead of standardized care. In other words, the process needs to be defined for a particular patient so that it can be individualized. So it should be standard process, not standard care.
That's a great point. Yeah.
This question for Eric. The whole political arena of government regulation, is there any good news going on within the United States that's going to reverse that, or is it?
The news that's important to me is we have a guy like Eric Paulson who's working day and night to fight the medical device tax that's killing companies such as ours. It's basically taking dollars that we would invest into research and development or invest in people to grow our business. I would say we're past the startup phase, but we're an early stage company. We have 120 employees and we're growing rapidly. But again, we are still getting slaughtered with the medical device tax, and we are in a losing proposition. And so Eric is doing a great job fighting tooth and nail on the hill to get that moving and revised.
I'll take it. We read about human genome sequencing and firms that are doing it right now for lower and lower cost. Is there, assuming you want to know what your defects are, is there a tangible benefit today to getting that done?
So the question is there a tangible benefit to having an entire genome done? And the answer to that is cautiously yes, because once you have it done, it's done. In other words, the one-off test of every time you walk into an office with a new complaint, a new targeted genetic test might be done, all of the information will be there for you. So, but having said that, there's an enormous amount of wasted information at the moment because we don't know much of what the meaning is of that entire genome. But imagine if you had the entire genome and a physician who's interested in your psychiatric care, your cardiology care, or your cancer care can query that that sequence for the knowledge that is there, having it done once, and the first genome was a complete genome, was done around 2000 at a cost of about $3 billion. That's what it cost. Today, the cost is about $1,000. So there's been a tremendous change in technology to allow this, and most people would argue in the next 2 or 3 years, a $300 genome is going to be possible.
Can I ask, where do you get something like that done?
Good question. So there are a number of places where these are being done. Most of them are in academic centers. So the University of Minnesota is now gearing up in January to do what's called whole exome sequencing. That's all of the sequences of all the proteins you produce. The Medical College of Wisconsin does it. So most of the places where the exome or genome sequences are being done are places that have that capability of computational approaches to actually query it. And at the moment, most of that is housed in academic centers.
So they give you a thumb drive? I mean, it just seems...
Literally, you can, yes.
Okay.
I had my genome done at a conference, and I had the genome done, and for the cost of the genome, I got a free iPad. And my genome was on the iPad. So they handed me the iPad with my genome on the iPad.
That's a good deal. I'd sign up for that. Yeah.
So this week I saw that an organization called 23andMe has some DNA testing for risk factors, but they say, yes, you should get some genetic counseling. Don't just go crazy if you find you're at a risk factor for a serious non-curable disease. But I checked it out last night since we were coming here. $199. What's that about? And that's what you might find on Google.com if you look at genetic testing, right? Because 23andMe, 23 sets of chromosomes, am I right? Is doing that kind of testing.
They're doing a much more targeted testing, and about 2 or 3 years ago, they got into big trouble with the FDA. The FDA was saying, you're doing these targeted genetic tests, and you're telling people their risk for osteoporosis, for diabetes, for a bunch of different disorders, and you're not qualifying that information about what that risk really means. And so they shut down 23andMe and say you cannot do that anymore because people aren't getting all of the information they need to make informed decisions. And if they go to their doctor with that information, most physicians didn't know what to do with that information. And mostly what was happening was it was creating more testing. That was a waste of money. And the FDA said, boy, if you're going to start scaring people with a small risk factor to go get tested for all of these things, the healthcare system's going to break. So they shut them down. 23andMe primarily now does ancestry. With the genetics, they can tell you your ancestral background and where you came from, whether it's Northern Europe, Northern Africa. They'll give you that information. And now they're slowly giving you risk factors for individual diseases with the oversight of the FDA that they're giving appropriate information as they do this. So they're rebuilding their portfolio now under the scrutiny of the FDA.
I think that was their news, that they were coming back and being allowed to do that again. I had heard it on NPR. So anyway, thanks for that. But that's the kind of information that's very confusing to consumers who don't know much about personalized medicine and might hear that news and think, that's what it is. I'm going to go in and find out my risk factors. Do I want to know? Will my insurance company do something with that, et cetera? And to me, I think consumer education has got to be a huge need in all these technologies. If there are, maybe we'll take one more question, and then we'll wrap up.
I think my question was just about answered. It was, is there a reason why I would not want to have that genome done?
That's a great question.
Great question. So that's one of the committees I'm on is returning results to individuals. You can't think of much more that's more private to you than your genome. And so that's very personal information. The question is, who do you want to share that information with? Do you want your employer to know your risk factors? Do you want your healthcare provider to know your risk factors and change your insurance rates? Do you want your children to know your risk factors that you may be passing on to them? So there are a lot of these questions that raise enormous social and ethical dilemmas about how private is that information, how is that information going to be used, and how is your privacy going to be protected? You have one really strong right. You do have the right not to know. So if somebody gives you a genome sequence and they say, I have certain risk factors, you have the right to say, I don't want to know. And that's strong. That's an absolute right. You have the right to say, don't tell me. But you might say, tell me everything. So when I had my genome done, I asked, I want it all. And my wife said to me, do you really want to know? And for me, yeah, I did want to know. In addition, for most of the genetic variations or mutations that might affect disease, I would have had them by now. So I didn't feel like I was 10 years old getting this information. Most of the things that would have gotten me by now. I have a defect in a gene that may impact blood clotting. Not that I'm a bleeder if I get cut, but they said that if you go in for major surgery, your surgeon may have to use a few extra cotton swabs to control the bleeding. But you might want to inform them that you have a factor 11 deficiency in your genome that may put you at a higher risk for bleeding. That's useful information.
Okay. Well, thanks. Thanks very much again, and thanks to Gillette Children's Specialty Healthcare for being here and informing us a little bit more about the great work that they do, and thanks all of you for supporting it and for being here. I want to just tell you about our next session, which is Media's Changing Role. Maybe we'll be able to coax Lee Schaefer to come back for that, but that is February 25th in 2016, and I hope that you're all interested in doing that. If you're interested again in learning more about the program, please contact me or anybody else from my team who's here today. So with that, thanks. We'll wrap up. Have a great day.